So thank you all for joining me. Good to see you all. Should we, we'll go ahead and get started, but just kind of moving into this, if anybody had any sort of like leading questions or sort of things that after they looked over um, the handout, if you had any questions that you'd like to start with, just so I make sure to cover that. I'm happy to sort of take any opening questions. There'll be lots of time for questions throughout the this hour. No? All right, great. So let's run through reflux. So part of the reason why I started with this particular condition is because so many people take medications for reflux, and many of them don't actually need that medication. That we can do some minor modifications, and that medication becomes unnecessary. If we have time at the end, we're going to talk about some of the research coming out about some of the side effects of some of the reflux medications, the long-term side effects. Really, in a short-term kind of a sense, we don't see a whole lot of, it's not a significant side effect profile, but that's something that we need to be thinking about, because these medications are ones that were really originally tested for a 2-week treatment regimen, and now there's people who've been on them for many years. So we want to think about what is reflux and what causes it, and then how do we treat reflux based on the cause, as opposed to just treating the symptom like we do when we take medications or antacids. So there's 3 major categories of cause for reflux. The one that's probably the most significant one is this so you have the tube that's your esophagus, right? So you swallow and it goes down the tube. And then there's a little muscle that closes off the bottom of that tube where it goes into the stomach. And it's called the lower esophageal sphincter. And that muscle is supposed to make it so that it opens up so food can come down, and then it closes up so that food can't come back up, right? So that muscle is really key to keeping what in the stomach, and keeping everything contained in there. There's a lot of reasons that we'll go over why that lower esophageal sphincter can get relaxed, but it's really one of the key players when we're talking about this. Another cause is an increased intra-abdominal pressure. So some of the ways that this happens is when people have weight gain, they'll notice that they'll get a little bit more reflux because there's a little bit more pressure pushing up. The other thing, because there's only so much room in your abdomen, right? And so it pushes up on your stomach, and that pressure can press against that closed lower esophageal sphincter and sort of overcome the tightness of the lower esophageal sphincter. Another thing that people often don't think about, and I actually didn't write it here, oh, I did say breath holding, is that often when people are anxious, they'll hold their breath, or kind of sort of tighten their belly, and that's going to increase the intra-abdominal pressure, which will then again push up on the stomach and sort of make it so that things are more likely to come back up into the esophagus. Tight clothing is something. So people like to wear different like shapewear and Spanx and things like that, and that also, you can think about how that presses on the abdomen, and again sort of creates a situation where there'll be more pressure moving upward than downward into the stomach. So those are all kind of little things that can be contributing. But I definitely find that often working with people around doing deep breathing can actually help a lot with reflux, if their major contributing factor is about breath holding. A lot of people think that they don't breath hold, but then if you catch yourself, it's like, oh wow, I'm really doing that. And breath holding doesn't just mean the holding your breath completely. It also means really shallow breathing when you're stressed. And then hiatal hernia. So hiatal hernia, what that is when you have, so your stomach is down here, right? Here's your diaphragm. I'm still working out how to do a little like ability to draw things, so I apologize right now. I'm just gonna do charades here. So we have the stomach here, and then here's the diaphragm, and if things are in good places, the diaphragm, which is that muscle that moves your lungs, is lined up with that lower esophageal sphincter. So they work together to close off the top of the stomach, right? If you have a hiatal hernia, what happens is the stomach itself kind of pops up above the level of the diaphragm, and now the lower esophageal sphincter is up here and the diaphragm's down here. Those two aren't lined up, so they don't get to work together. So it just doesn't work quite as well. You also have this little part of the stomach that's above the diaphragm that then is going to have a little bit higher pressure as well. So it's more easily sort moved upward because of that, the pressure of the diaphragm pressing on that little balloon that's above the diaphragm. So hiatal hernia is something very common, not a severe condition or anything like that, super common. However, it can create a really hard to treat reflux, and we'll talk about some little tricks that I really they're old school tricks for hiatal hernia. So mostly people, when they have a hiatal hernia, it's discovered during an endoscopy, which is when they put the camera down your throat and look at your stomach, and it can be reduced, which means kind of pushed down during an endoscopy. Sometimes there's even a little procedure to get it to try to stay there. A lot of times it's just left there and it's like, oh, you have a hiatal hernia. A lot of times that hiatal hernia is considered an indication for the use of proton pump inhibitors to prevent the reflux from happening. However, I really think about there's things we can do to try to reduce that hiatal hernia. So those things, we're going to start with the hiatal hernia things just because they are, we're going to kind of go from like the least to the most complicated in terms of how we treat these root causes. So hiatal hernia, again, where that stomach is kind of pooched up above that diaphragm. My favorite treatment is called heel drops, and it seems ridiculous and silly, but it really works. Actually, I've seen it cure some very difficult to treat cases of reflux. So what you do is you wake up in the morning, nothing else in your stomach, or really it can be any time that you don't really have anything else in your stomach. So a couple hours after a meal, you drink 8 to 12 ounces of water. And then you go up on your toes and kind of fall back on your heels. So you kind of just sort of go up and then poof, like fall down. So that's and there's lots of great, YouTube videos that you can look at in terms of looking for heel drops and what the heel drops look like. But pretty much you can just imagine. Oh, good question. Is there an exercise for us to close the sphincter? No, there isn't, but we can definitely work on that. So I can talk to you about how we can strengthen that. So actually, I should probably demonstrate this. So we're gonna go. Let's see. So you go up on your toes. Here, let's see if we can do. You go. This is not working all that well. Sorry, I should have anticipated that I was going to do this. So you're up on your toes, and then you just let yourself drop. So your whole body kind of goes boof, boof, like this. So really, with as much impact as you can muster with that heel drop. So let's see. There we go. All right. So another thing you can do is visceral manipulation, and probably the best way to show you how to do that is to have you come in the office. It's one that's pretty hard to do over a video, but pretty much what you're doing in doing visceral manipulation is just sort of pushing down from your left upper quadrant, kind of pushing downward. And sometimes when we do that, people feel a little bloop feeling, and that's what we're doing is pulling that stomach down through the diaphragm. Again, there are some YouTube videos about it, but also I'm really happy if you ever are in the office to just show you how that's done, or even if you want to come in and make a 15-minute appointment. So I demonstrate that for you if you do have a hiatal hernia and like to address it in that way. So, and then the third way is really what I talked about in terms of while they're doing the procedure of the endoscopy, they can push down on the stomach and kind of pull it so that it comes down so that the lower esophageal sphincter and the diaphragm are lined up. But really, out of that whole list, I really want you to focus on those heel drops, partially because even when we do the visceral manipulation, what I find is that very often it'll relieve the symptoms for like a day or 2 days, and then they'll come back. And that's partially because when a person has a hiatal hernia, it actually stretches out that part of the diaphragm. And so it makes it more easy for that stomach to keep on going back up. But if we do the heel drops every day, it keeps the stomach down so that way that stretched out part can kind of close back up again. So, doing a visceral manipulation once a month is not as effective as having something that you can do every single day, like the heel drops. So that's why I love heel drops, because you can do them at home every day so that we have the best outcomes for pulling that stomach down, but also closing it up, healing up the diaphragm so that it can't pop up quite as easily. So, in terms of how do we go about decreasing intra-abdominal pressure? The practicing deep breathing and avoiding breath holding. So really sort of, catching ourselves, like, sort of on a, some people even set like a little alarm for themselves. Some people have like a little reminder to themselves about really catching themselves, shallow breathing. Some people even have watches that will tell them that they're shallow breathing, which is kind of a nice thing to break some of these habits. We need a little bit of a reminder about that. So if you have reflux and you're not sure if you have a hernia, it doesn't hurt to do the heel drops. So heel drops aren't harmful. You're not gonna. And so you can, if you have reflux and you've tried all the other things on this list and it hasn't helped, then you can always do some heel drops. Not going to hurt, but could really help. Avoid restrictive clothing, of course. So that means that especially if you're having symptoms, that knowing that taking off your restrictive clothing can be helpful. And then another thing, really in terms of, this is also something to really prevent yourself from having a hiatal hernia, is to really practice careful breathing out when you're lifting anything heavy. And that includes things like moving a pot on the stove or picking up a child, or, things that we don't really even think about that we're doing. So we always think about it when we're like moving or helping someone move or, doing something really heavy, but we often don't think about it with those sort of smaller things that are part of daily life that we lift and move around. So really kind of training yourself, practicing that breathing out while you're lifting anything heavy is just a really good, important practice as well. So now this is kind of the biggest part. Those two we can kind of, bounce along with. And and so now we're getting into that relaxed lower esophageal sphincter, but there is a question here about a product that lets you know how we're breathing. I don't know which one it is, but I think it's it might be the Apple Watch. My Apple Watch doesn't do it, but it's one of them, or the Aura Ring maybe. I'm actually not sure. I shouldn't even be trying to guess because I don't know which one it was. Somebody was just telling me that they had a thing that would like give them a little reminder that they weren't breathing very deeply. So sorry, I don't have specifics on that. So in terms of the lower esophageal sphincter, unfortunately, it's not a muscle that we can train or exercise. It's a smooth muscle, so we don't have any conscious control over it. The big things that that help to strengthen the biggest thing that helps to strengthen the lower esophageal sphincter and make it close tighter is protein. So protein sends a signal that makes that lower esophageal sphincter close. The other thing is actually melatonin. So if you think about it, it makes sense, right? It's like when you're sleeping, you want to have that lower esophageal sphincter very close so that you can be lying down and it'll be okay. I use melatonin therapeutically quite a lot when people have relaxed lower esophageal sphincters and frequent reflux. And then there's a lot of things that relax that lower esophageal sphincter. So there's a lot of culprits there. The biggest ones, the ones that are kind of the most impactful, are really caffeine and alcohol. Those two have the greatest impacts. So one of the things about caffeine, specifically, actually, I'm going to be even more specific about coffee, is I always tell people who have any kind of stomach upset, never coffee on an empty stomach. And even then, some people, if they're drinking coffee after they eat, they can actually, some people can't tolerate that as well. So coffee does two things, because it increases the acidity of the stomach, but it also relaxes that lower esophageal sphincter. Decaf is a little bit better because it doesn't relax that lower esophageal sphincter as much, but it does still increase that acidity a little bit. So for some people, it's still an irritant. So there's also low acid coffee that is available. I also really enjoy the coffee alternatives. There's this one called Teccino that's delicious, and it's made from herbs. So it's TEECCINO, and it's quite delicious. They have a bunch of different flavors and everything, but it has that good bitter coffee taste and the good strong smell, but it's low acidity and it doesn't have any caffeine in it as well. So I just love a cup of coffee, and also there's ways that my body doesn't love it. It depends on the day. So then the other things that, so those are the big ones, so caffeine and alcohol, biggest triggers for relaxing that lower esophageal sphincter. Oh, and smoking. I actually should put that one on that list. And then kind of underneath that, we have a lot of other things that cause that relaxation. The next one, kind of in terms of if we're listing it from most impactful to least impactful, the next one is chocolate. So for a lot of people, chocolate is a major trigger. Also, simple carbohydrates of any kind. So that includes eating bread, especially bread without protein. So anytime we add a protein, we're going to strengthen that lower esophageal sphincter and balance out the effects of that relaxation. So for some people, the way that they are able to tolerate having a glass of wine on occasion is I tell them, make sure you just eat it close to dinner, start eating your protein before you drink the wine. And a lot of times that'll actually balance it out. The other thing, in terms of dessert, if there's going to be a dessert, if it's a special occasion or something like that, trying to eat dessert as close to the dinner as possible also helps to make it so that dessert doesn't cause as much of that relaxation of the lower esophageal sphincter, because presumably there's a good amount of protein in dinner, and then that will balance out that effect of the sweets or the sugary foods. Then this one is actually, this one's kind of like buried in here, but if there's only one thing that you take from this entire workshop, eating slowly and chewing carefully is one of the best things you can do for your digestion, and specifically for reflux. So there's a lot of things that happen when you're chewing slowly. One is like the first thing we think about, right? That like the food gets mushed up and easier to digest because it's easier to get down because it's mushy. But actually, as we're doing that, a bunch of things are happening. So it stimulates the production of digestive enzymes, and it stimulates the movement of the bowels. So I don't know if you ever had this happen, but when you chew gum, sometimes you ever notice it can make your stomach rumble. Part of that is because it's stimulating your whole digestive system to sort of like wake up, is probably the way to think about it. The other thing it's doing is it's stimulating saliva production, and saliva is the sort of unsung hero of the digestive system, because saliva actually contains so many different factors that are really important for protection of our esophagus and our stomach. So there's something called TGF alpha that's really important in terms of protecting the lining of our esophagus and stomach. It also contains a little bit of bicarbonate, so that actually helps if you eat acidic foods, your saliva itself will create the bicarbonate that will make them a little bit less acidic going down your esophagus. It also creates this prostaglandin E2, which is part of like creating like a barrier in your esophagus and your stomach that protects your esophagus and stomach. So saliva is incredibly important. And if we do what we often do, which is throw down some food as we're running from place to place, there's often very little saliva production. And so one of the things that in terms of like food, they call it food hygiene, which is how to eat to optimize your digestion. One of them is trying to be able to smell food before you're eating it. And it's kind of funny that when you really think about it, in our modern world, that doesn't happen all that often. If you're running from one place to another, you're just grabbing a protein bar or whatever. There's a lot of occasions where in modern life we end up not smelling food at all before we eat it. And what happens when you smell food is, again, that same kind of thing like I was talking about when you're chewing. It wakes up your digestive tract. It makes you make the digestive enzymes. It makes you start salivating. So one way to be able to make that happen, if you're not in a situation where you can smell food, is to think about your food before you're about to eat it. And the way you've done it enough is when you feel some saliva forming in your mouth. So if you're about to eat that protein bar, on your way from point A to point B, think about the protein bar before you get into before you're doing it, to the point that you have saliva in your mouth, and then chew and eat that protein bar very slowly. our digestive systems, I always think about that they're not really made to be surprised by food. Like really, the idea that right now we can surprise our digestive system with food because there's so many foods available that require little to no preparation. So you think about what a new thing that is in mammalian history is that the idea that you could, even because refrigeration is so recent, and so the idea that you would have a prepared food that you then would eat is, is very new, and so that normally kind of like that process of preparing food, of cooking food, of smelling food, of thinking about eating food, there's usually a pretty big lead up, usually in terms of mammalian history, a big lead up to eating, versus what happens right now, where you can have food sort of surprise your system by arriving without much lead up. So anything you can do to slow down the process of going from not eating to eating is really excellent. And chewing is one of the very best things you can do for your digestive health. And really in a lot of ways for all of your health, because anytime you're supporting your digestive health, you're supporting your assimilation of nutrients, you're supporting your basically your nourishment. So also another thing in terms of strengthening that lower esophageal sphincter is that melatonin, like I mentioned. So I often use that therapeutically at a very low dose, so that 1 to 3 milligrams. There's a lot of controversy out there about melatonin right now. A lot of it is around the issue of people using high dose melatonin supplements. So that's like 10 to 20 milligrams, which is a lot of melatonin. I mean, that's greater than what your body would create. And it is also true when people say that 1 to 3 milligrams is greater than what your body would make. But actually what gets absorbed is actually more comparable to what your body would make. But keeping that a really low dose melatonin and then chewing it, or I have a liquid melatonin. And what that does is it strengthens that lower esophageal sphincter at night. So when people come and they mention that their reflux is really severe at night once they lie down, melatonin is one of the places that I start. Also, I mean, it's also helpful for reflux throughout the day. So just by strengthening that lower esophageal sphincter at night, it sort of creates more of a baseline of a tighter sphincter. So that is another way to do that. The other thing is really to avoid lying down within 3 hours of eating if you're having quite a lot of trouble with that. One of the things that I noticed too is that women going through menopause, that as their estrogen decreases, their production of melatonin can also decrease, and that so often that's something that comes up around menopause and then can persist after that. And so both that kind of having a routine that includes avoiding eating within 3 hours of eating, or going to bed, but also that melatonin can be helpful. And sometimes even doing other things that support melatonin production, like making sure the room is dark, wearing an eye mask, those kinds of things, taking a shower before bed, those all can increase the melatonin production, which could also help with the reflux, along with sleeping issues as well. Another thing actually that I just realized that is not on this list is about how stress relaxes that lower esophageal sphincter. So when people are feeling anxious or stressed, that lower esophageal sphincter will open a little bit. And that's partially the way that I think about it in terms of what all of the effects on the digestive system from stress, is that your body is kind of shunting energy away from your digestive system. So it's when you're under stress, your body is kind of reading like, oh, hey, I'm in a survival situation. I'm probably going to need to run away from something or chase something. And it's going to sort of take a lot of that, emphasis away from digestion. And you're going to produce less digestive enzymes, less of that protective lining of your stomach, less movement of your bowels. So things won't move out of your stomach quite as easily, which then also can cause reflux because there's a greater amount of time that your food is sitting in your stomach. So stress, this is not the easiest one to address or to treat on this list. So I think I kind of focused on the ones we can treat a little bit more, but again, swinging back to, doing deep breathing exercises, even if there's a lot of stressors in your life that you can't control, doing things like meditation and breathing exercises can help you to modulate your physiologic response to those stressors, and can help you modulate your own body's sort of reading of the world as a dangerous place, or as something that you're kind of modulating your own internal response to those stressors by doing the deep breathing and meditation. So any questions about all of that? Okay, go ahead.
Where do probiotics come into any of this? Does it?
Yes, absolutely, actually. So probiotics are like a mystery factor when it comes to reflux. So especially in babies and children, there's been a lot of studies showing that that probiotics are the treatment of choice for reflux. And I find in adults sometimes as well that they help. As far as I know, no one really knows the exact mechanism on that. When I sort of, if I were to theorize about what the mechanism on that would be, is that the probiotics themselves create more of a tolerance reaction in the whole digestive tract, and so that helps the with motility, and it helps with like the protective lining in the stomach and everything else. Oh, which actually another one to add to this list as well, which is actually a whole other cause, and sometimes plays in, is food intolerances and food allergies. For some people, the foods that they're intolerant to will cause more reflux, and it's a little bit tricky because that's a little bit of a circular issue, because partly the food intolerances themselves are often caused by difficulty with digestion, which is often caused by a lot of the things that we just talked about, and so, or simple carbohydrate intake, or so sometimes there's a bit of a cycle there. However, I have seen for some people that when they identify the food that they're intolerant to, and surprisingly, the number one food intolerance that causes reflux is actually dairy, which is the reason I said that's surprising, is because a lot of people have been either told or do this themselves, that they eat dairy when they have reflux to try to calm it down, and it will work for a brief period of time because of the way that it contains buffers, like things that reduce acid levels. But then if they have a food intolerance to it, it will actually make then their reflux worse in an hour or two.
Mm-hmm. Does it matter if the probiotics are refrigerated or not refrigerated?
Ooh, yeah. So I actually should teach a whole class on probiotics, because there's a lot of controversy about this, and really a lot of it we don't know is the answer, because so people, if you ever run into someone on the internet who's like, this is the way it has to be, these probiotics are the best, and blah blah blah, this is, you must, the one that I always kind of like laugh about is that some people are like, you have to take probiotics away from food, and other people are like, oh, you should take them with food, and really the answer is no one knows. There's a lot of a mystery around. We know probiotics do so much, but we don't know what they're doing and how and why. One of the things that really like puts a light on this is that there's some European companies have been doing some research about heat-killed probiotics. So they actually take the probiotics and specifically kill them, and then see, to see kind of what the effects of that is, and actually they're finding that sometimes it has even greater anti-inflammatory effects, because and so that's something about the process of actually like heating them up actually releases some anti-inflammatory compounds. And so people are making these lists of these compounds that are made by the bacteria, and then what other ones are made. And so, but here's the thing, is that I just went to a conference about this recently, and the real thing is we know the effect, but we don't know why we get to that effect from probiotics, because a lot of probiotics don't actually even really make it through your stomach and into your intestines, right? To get a probiotic all the way to the colon is a feat, right? And so a lot of them have these like enteric coated and make so that they're made to withstand the stomach acid and then make it to the intestines. And so a lot of them probably do make it, right? But at the same time, there's also this whole other set of effects that's actually not about the bacteria themselves, but it's about the compounds that the bacteria produce that have that anti-inflammatory effect. So here's what we do know about probiotics, is that there's a lot more live organisms in the refrigerated ones for the most part. That there are certain strains that are well studied, and there's other strains that are not as much. So if people are really into the soil-based organisms, there's really, somebody asked me about it, and I went in to look at the literature, and there's very little literature to support the claims that are being made. And this happens so often. If you get onto a website and they're like, this is the best ever. Like do the, like, look at their references and look at those references. And, if the study says that it was 3 people, then that this is not a valid study. And also too, sometimes you look at the markers and it's actually not even statistically significant what they're claiming to be an outcome. So the world of sort of skewed reading of research is huge, especially when someone has something to sell. And probiotics is an area where that we see that probably more than in most areas. And so the in terms of like strains that are well studied and working with the ones, when I went to a probiotic conference, and one of the ones that really comes up, like that Therabiotic Complete by Yale, by Claire Labs, that I use often, that's a really excellent one. Sometimes I also use one called Orthobiotic, which also contains Saccharomyces boulardii. So Saccharomyces boulardii is actually more in the yeast family, but it is the specifically the one that's most associated with anti-inflammatory activity and inflammatory bowel disease, and also in treating and preventing Clostridium difficile, which is something that people get after using antibiotics sometimes. So yeah, probiotics. I should probably teach a whole class on them because they're great and they're fascinating. Basically, the best way to think about probiotics is getting fermented foods really is excellent. Using to be those 2 probiotics are really the I think the ones that sort of represent the research that we have so far. The orthobiotic is actually a shelf stable one, but I still use it because of the way that they can show that the bacteria are still alive. So definitely probiotics is another one to add to that list, and probably we could add it to that list of like the foods that can help to reduce GERD, and that includes all like fermented foods in general. So the foods to avoid when you have reflux. So as we talked about, caffeine, alcohol, fried foods, spicy foods, tomatoes, citrus, chocolate. Oh, I put spicy foods on there twice. Sorry about that. Vinegar. So vinegar is an interesting one. Some people use apple cider vinegar to treat their reflux, and they get a lot of good results with that. I find that for a lot of people, vinegary foods make reflux worse. So one of the ways, the vinegar often hides in like dressings and sauces. And so just to kind of, you'll know pretty quickly if you're a person who reacts to vinegar, just to eat a salad with a vinegary dressing and see how you feel with that. Which actually vinegar kind of brings up another topic that gets thrown around a lot on the internet, which is this idea that people have low stomach acid and that's why they have reflux. It's sort of a misnomer. It's like it's a valid point, but it's also kind of a little skewed, right? So it's not that the person has a problem with producing stomach acid. There are a few conditions that someone really has a profound issue with producing stomach acid. So there's ways that people can have gastroparesis, which means their stomach is just really not very functional. It's not moving very much and it's not producing stomach acid. However, when I think about, people are like, people have low stomach acid, we have to give them more acid in order to help them break down the food. Yes, and, it's when I like to think about is why do they have low stomach acid? And very often, a big source of that is about stress, but also about chewing. So it's kind of like everybody, there's so many things we want to have a pill for, but a lot of times taking more stomach acid is helpful to an extent, right? The other place actually where I do often use kind of longer term supplementation of something that's a little bit acidic is when people have undergone chemotherapy a lot of times and it's affected their digestive tract. A lot of times that is a situation where people will end up with a low stomach acid production. The indicators that I always listen for that tell me that a person has low stomach acid production is that they tell me that if they eat something that's high in protein, that it sits in their stomach like a rock and doesn't move, or that they have a lot of belching after eating something that's high protein. Those 2 things will make me kind of say, I wonder about this stomach acid. and whether or not we need to actually support it a little bit. What I often do to start with, so again, if you read on the internet, they're like, oh, just take hydrochloric acid. You can do some damage by taking that acid, especially if you did have like a developing ulcer or something like that. So we want to be cautious about that. What I often start with when a person has kind of a low stomach acid is both talking a lot about chewing, but also digestive bitters. So digestive bitters are, you can use regular old cocktail bitters from the store, but also you can use, gentian is one of the big ones that we use. I have something from Herb Farm that's called Better Bitters. That's a spray that I like quite a bit, and it's really nice. Digestives have been something that have been, in a lot of cultures for a lot of years, whether it's like a, even something like a hoppy beer is kind of a digestive because it has that bitter quality that can stimulate that digestive function. So that spray is really lovely because you can feel it make saliva, and you can feel it start to kind of wake up your digestive system. So that's a great place to start. I always love to start with something that supports your own body and doing. Sort of is like the first thing we do is say like, hey buddy, like tap tap, like what do you think? Can you do this? And or can we help you do this? Or can we nourish you so that you can do this? Versus coming in with like a heavy hand and being like, here's some stomach acid, there you go. But there's times and places where we do need to bump it up to adding a little bit of stomach acid. And when we do that, a lot of times we can do it for a short period of time and then stop, and then the person continues on making that stomach acid. And like I said, there's certain conditions, not very common, that we need to continue supplementing that stomach acid. And the other thing, for some people, peppermint is another one that can cause more reflux because of relaxes that lower esophageal sphincter. So if we can add to that list peppermint there on that foods to avoid when you have reflux. Some foods, again, food is medicine. I see that all of you were there for that class, and so you all know about cabbage. So just to review cabbage, eating it helps to strengthen and heal the stomach lining. It also helps to reduce reflux and even drinking cabbage juice, it can be very helpful as well. Bananas is another one that's very helpful for people. Again, kind of has that mucilaginous quality to it. And then high fiber foods like celery, beans, broccoli, cauliflower, whole grains, green vegetables, squash. When we eat enough fiber, it actually creates sort of an actual like physical barrier that makes it so that it's hard for the stuff to come out of your stomach because that tends to kind of float to the top of the stomach. The celery is my favorite trick for during pregnancy when people have there's a lot of reasons why they have reflux and they have nausea. But that celery, when it creates that physical barrier, because progesterone is a hormone that will relax that lower esophageal sphincter. So some people notice, people who are cycling menstrual cycles, they'll notice that they get more reflux at the end of their cycle, and that's because of that progesterone. And celery is a great way to sort of counterbalance that, partially just by, and also I guess the other thing would be to eat lots of protein to counterbalance that as well. Melons actually really, it's from a Chinese medicine perspective. This is, great. Yep. The cantaloupe, absolutely. And Chinese medicine would say the melon is very cooling. It's kind of cool and damp, whereas the reflux is a representation of things being kind of hot and dry. And so the melon kind of counteracts that. I do find that is one of the best things for an acute situation. Fennel is also really lovely. So you can actually take the regular fennel from your spice cabinet and put it in some hot water and make it into a tea. It's really great for reflux, but it's also really great for gas and burping. It just sort of settles the stomach really nicely. And then in terms of some natural medicine things that I use, DGL is one of my go-tos. I like DGL because it's anti-inflammatory. It's deglycerinated licorice. So what it means is they take the licorice root and they remove the part of it that is I didn't actually put this on the handout partially because I didn't want anybody to get this handout and self-treat. And, you know, we do have to be careful about some of those things. So this way I can explain it a little bit more. And I feel okay about it in this context, but having it just written out there as it doesn't matter what kind of cabbage. It can be green cabbage, purple cabbage, whatever you like. Yeah, for the purposes of glutamine, any kind of cabbage is great. So that DGL, it's really anti-inflammatory. It's not, I'm talking about something that's not on the handout because I didn't put it on the handout because it's sort of in treatment mode, and I don't really want to have something on a handout that someone would be like, oh, she told me to do this, you know, and without the full explanation around it. So so deglycyrrhizinated licorice is something, they take the licorice root and they take out the glycyrrhizin. So it's just called DGL. And that's something that you chew and swallow if you're having reflux or if you're having stomach gastritis is the other place I use that, which gastritis means an irritation of the inside of the stomach. So that's my real go-to just because it works so well. And it not only is treats the symptoms, but it also helps to heal the stomach and esophagus, preventing any kind of esophageal irritation or ulcer, you know, and also it has a little anti-H. pylori activity. So H. pylori is the bacteria that can create a situation where ulcers can develop, and it also can disrupt the lining of the stomach. So a little word on ulcers. One of the things, you know, so this is where, you know, definitely if you're having any of the following symptoms, I really want you to contact me or your doctor about this. So whenever people come in and they say, I have a pain right here, and they use their stomach, their finger to point to a place, I immediately say, oh dear, maybe there's an ulcer. And then whereas, you know, a lot of gastritis is kind of more of a generalized sort of a feeling. Another thing is if they're having anything that looks like coffee grounds in their stool. So what that tells us is that there's bleeding happening from the upper gastrointestinal tract. It'll look like coffee grounds when it's coming out. And a lot of times those, there'll be a different smell too, a significant change in the smell of the stool. I can't really describe what that smells like, but it's a change. And then also waking up at night with a very severe pain, that can be a sign of an ulcer as well. So basically know that what we're talking about today is really for people who have kind of like every once in a while they get a little bit of reflux. If you're having any kind of severe abdominal pain, definitely it's time to talk to a doctor directly about that and get a proper diagnosis and treatment. That's great that melon works just as well as the DGL. So we heard from a member that the melon actually works just as well as the DGL for kind of immediate treatment, and that's wonderful. In terms of the DGL, where you can get it at any health food store. You have to be careful about taking it too close to other medications. There's certain medications they have to be careful about taking it close to. And if you have any specific questions, you're welcome to email me about that. I won't kind of be specific about that. And you can, it's because it has the glycyrrhizin taken out, you can take, it comes in a little tablet form, and the dosages are different, but you can take up to usually, I'll say kind of without medical oversight, 4 tablets a day is a good amount. But if you find yourself taking more than 4 a day, you would definitely want to be seeing a doctor. Or if you find yourself taking it every day for a period of time, you would definitely want to be seeing a doctor. Just like Tums or any of the other antacids that people use, is that if we find it to be, if it's like, oh yeah, I know that every time I eat pizza I'm going to have a little trouble, that's something it's okay to work with. But if it's something that's happening daily, or if the pain becomes severe. There's also some other things. Sodium alginate is another one. I don't use it that much, partially because it's kind of expensive, but that's one that there's been some studies showing that that's helpful for preventing reflux. What I noticed clinically was that when I first went to a conference and learned about sodium alginate, I was like, oh, let's try this. But I actually think DGL works much better, so that's what I use, and it's less expensive for people. So I've kind of leaned in that direction. The zinc carnosine is also a great one. So it's also under the title Pepzin. And that is one that is helpful for healing the stomach lining, and also can help with reflux sometimes for people. So those are kind of like my go-tos, but really part of the reason I started with this as the class is because GERD is one of those things that that, you know, we can really address from a root cause perspective, and people just don't have it anymore, versus trying to patch up the symptoms of it. That's always a little bit, doesn't really get us as far when we're trying to treat it, from a symptom perspective. Always, pretty much in general in health, it's always better when we can prevent it instead of treating it, right? But there's a time and a place, right? So in terms of any questions about all that, anybody have any like sort of feedback, questions, or things that they've found that really helpful for them? Oh, one more thing, actually, in terms of my treatment regimen for reflux, ginger can be helpful. Yeah, ginger for some people is very helpful. For some people, it actually can make it worse. So you can try that out on yourself and see. I don't like generally recommend ginger, but fennel I do, because of that. Like, oh, it's either going to work great or not so much. There's also an acupressure point. If you take, this one's also really good for nausea too. If you take from your wrist, you go down 3 finger widths, and then you get right into here, you'll find a little tender spot right here. It's kind of like right next to it, like that big tendon there, right in the middle there. And with acupressure, it's nice because you can kind of just find the area and then just find the place that feels a little tender. And then you just rub that spot. And that's really good for nausea and for heartburn as well. So I love to be on boats, and I get really nauseous. And this is, I'll get bruises right here after that, because it works really well. And also, so it's a good one to have in your back pocket if you don't have any antacids or melon or DGL with you, you can work that spot there. So anything, okay, let me make sure I answered any questions here. Okay, good. So I do want to have a little discussion about the proton pump inhibitors, just because there's a lot of information out there, and some of it is overblown. So knowing that, you know, again, in the world of the internet, people really like to sort of take studies and pretend like they say things that they don't actually say. You know, kind of like a study might ask a question about something and might raise a question or might say, oh, there might be a correlation here, but then you read the headlines the next day and it's like, this causes this, you know, and it's like, no, actually not quite, you know, like, so there's so many things in medicine that are not definitive, that people kind of want to state as if they're definitive. And especially I find that in the world of, you know, bloggers and the internet and people selling things, that people state things as if they're much more known than they are. Like, the human body is so complex and so beautiful in its complexity that, you know, that really there's a lot of limitations to what we know and understand. And also there's a lot of limitations to know what we know and understand about what happens when we intervene in one way, and what the ramifications are of that around that issue, situation. And so one of the things, you know, these proton pump inhibitors were really first approved for 2-week use. And so now we have people who've been on them for a decade. And when I say proton pump inhibitors, I'm talking about like omeprazole, pantoprazole, you know, the most common ones there. And the H2 blockers are a little bit different. So we'll talk about those a little bit as well. But the most common, we'll kind of work with these most common medications, that the proton pump inhibitors, and just sort of what we're seeing. So this, I put a couple of different references if you like to look at the studies, but I really like this one. The Mayo Clinic does these sort of reviews that about the literature, and this is the last one listed there that has that link there. If you're really interested in learning about this is the one that I would read, about if you were interested about side effects. So it kind of reviews all the studies that have been done and sort of some of the suggestions, you know, about possible correlations. And these are always hard because we can't, it's hard to have a single variable in this situation, right? So, you know, even if we think about things like, you know, bone fractures, right? So is a person who is needing long-term proton pump inhibitor therapy, someone who by nature is also not eating as many vegetables. So that's why they're have a higher risk of fractures. Like there's so many different, things that we can't really control for in a study, especially at this kind of duration, that get pretty tricky. What I do know clinically, like, because I definitely, these two things are very correlated clinically, is one is that proton pump inhibitors can cause low magnesium levels. So what this looks like is often cramps or twitches, or for some people, like increased heart rate. For some people, sort of an increased anxious feeling. So they could definitely cause a low magnesium level. They also can cause low B12, and that's partially because the way your body absorbs B12 is very complex and requires stomach acid in order to bind this B12 to this little carrier molecule. It takes it to where it can get absorbed. And so, when people are on long-term proton pump inhibitor therapy, I'm really looking more carefully at their blood count to see any signs of B12 deficiency, and sometimes making sure that if they're on, any, like, picking, if I have a couple things to pick from, if someone's on a proton pump inhibitor, I'll make sure I pick the one that has a little bit of B12 in it, as opposed to the one that doesn't, just to cover the bases, give a little extra, because of it being a little harder to absorb. The small intestinal bacterial overgrowth is something that is getting a little bit more attention lately, and there's a lot of controversy about it, but I'll just kind of run you through what it means. Is that you shouldn't have a whole lot of, or really shouldn't have hardly any bacteria in your small intestine, but some people have get an overgrowth, and what it looks like clinically is a very painful bloating, and often it can be also associated with diarrhea or constipation, but that painful bloating and that burping, and the way that I sort of distinguish it from different food intolerances and things like that is that it has a persistence to it. So it's really a daily experience of painful bloating that people have. And one of the ways that proton pump inhibitors make people have more risk of small intestinal bacterial overgrowth is that by reducing the acidity of the stomach, we're now kind of like, opening up the gate. Usually that stomach acid keeps a lot of bacteria from going into the digestive tract. And if we lower the stomach acid, now it's more possible for that bacteria to make it through the stomach. So then there's kind of like possible associations that are listed, that multiple studies are asking this question about whether or not it increases the risk of fracture. And it's partially because of how it disrupts the absorption of magnesium and calcium. But there's one study in here that did say that it's possible that it also affects the ways that the osteoclasts, which are the ones that the cells in the bones that make more bone, basically, is that the proton pump inhibitors actually might inhibit those osteoclasts from continuing to build the bone. So again, all of this is like a big question mark right now, but probably we'll get more information about that soon. There's also some associations with kidney disease. And again, whether that could be related to magnesium, like that could be a secondary type of a thing, but there is kind of a growing concern about that, but it's very much not established yet. If you read some things that people have written on the internet, they'll tell you that, like, if you take a proton pump inhibitor, you're going to have kidney failure, and that's just not true, actually. And dementia is another thing that there is. There's so many medications that have a anticholinergic activity. So a lot of the antihistamines, we'll talk about that at the allergy class, also have an antihistamine quality. Anticholinergic activity, and that has been associated with an increased risk of dementia. So again, that's a very low association, because these don't have a whole lot of that activity, but that's the one of the possible associations there. So in terms of like what we're talking about when we say proton pump inhibitors, that's omeprazole, pantoprazole are the two top ones. Most of them end in azole, and so those are kind of the ones that get used the most there. And then there's this little question about whether or not it increases the risk of pneumonia, but that we won't even talk about that because it's not really not really associated, but it's out there as a question. So anyway, there's this kind of, you know, and when I think about whenever we want to use a medication, there's a time and a place, right? So there's, you know, conditions like Zollinger-Ellison, which is like a pathological condition where people are overproducing stomach acid. And that absolutely a proton pump inhibitor is indicated there, because if we don't do it, it will have pretty severe consequences. Another situation is where, you know, somebody has a severe hiatal hernia. Sometimes we really need to do that so that they don't just sort of wreck their esophagus. You know, that's so it doesn't, you know, destroy their esophagus. One of the main reasons that proton pump inhibitors are used is to try to prevent the cellular changes of the esophagus. So what happens is when really any part of the body, you know, same thing with like lungs and smoking, is exposed to a constant irritant, you start to have cellular changes that eventually turn into cancer, right? So in the esophagus, you have, you know, esophageal changes that then turn into Barrett's esophagus, which means it's kind of a precancerous condition. And then that change moves to esophageal cancer. And so the main reason, the sort of rationale for using proton pump inhibitors so widely was to prevent esophageal cancer, right? And that's how it's been, you know, since they began, since they came out. Fast forward to 2017, this big Danish study came out, which I included in the references there, that actually showed, and I'm so surprised that this is not kind of coming out into medical practice more, but it always takes a year, you know, 5 to 10 years for something to go from a study to like changing the way we practice medicine. But it actually showed that the proton pump inhibitors do not prevent the progression towards Barrett's esophagus. So they actually, you know, if you have, you know, groups of people with reflux that, you know, with and without treatment, and the people who didn't get treated with a proton pump inhibitor don't have any increased risk of developing Barrett's esophagus than the people who did get treated with a proton pump inhibitor, which is actually like a big deal, right? Like I was actually quite surprised that this study was not like sort of, you know, bouncing off the walls in the you know, all the medical conversations and conferences and everything. And I think, you know, part of it is that it's hard to sort of like change beliefs, you know, and it's like, you know, if you know, most people have been practicing for all of these years with the belief that like it's really important to get people on proton pump inhibitors to prevent them from having esophageal cancer, it's pretty hard to shift that, right? So we've all been sort of working under this assumption or this belief, and this study really sort of blows that out of the water and says, actually, no, that's not really what we're doing. And really, you know, part of this also comes from, you know, the fact that, you know, doing all the things that we just talked about does take a lot of dedication. It does take a lot of, you know, modifications of a person's life and eating habits and everything else. And some people, you know, some people prefer to take a pill. And I always think about, you know, like that's a person's body, it's their choice. And also, I always wish that there was more of a sort of an awareness of risks involved with taking that pill, because generally it's prescribed and people think of it as an innocuous pill that just helps you not have reflux. However, you know, we do see that there is no such thing as really an innocuous intervention, even in natural medicine. You know, that's really, you know, we always have to weigh risks and benefits, but we know there's some things in like that we can see on this list here that are, you know, that have no negative side effects, right? Like practicing deep breathing and meditation, like, yeah, no, like there's not going to be a negative side effect there, you know, or, you know, chewing more carefully, you know, yeah, it'll take a little bit longer to eat, but really what people are often surprised by the fact that it doesn't take that much longer to eat when you're chewing more carefully. You know, it might add an extra 5 to 10 minutes, but can have a pretty profound impact on digestion. So we just have a couple more minutes. If anybody has any other questions that to go over, or anything you want me to review that we talked about. Alrighty, great. Well, it was wonderful to see you all. I like that this is like the crew. I really appreciate that. I really appreciate each of you for coming. And I look forward to seeing you all at the next one, which I think is the allergies coming up. So we'll see you all in a little bit. All right. Thank you.
Bye. Have a good day, everybody.
You too. Bye-bye.